Vulvar carcinoma is a cancer that starts in the skin or lining of the external female genital organ called the vulva. Historically, it was thought to be a very rare disease, but better awareness has shown it occurs more often than once believed. The vulva includes the labia majora, labia minora, clitoris, and the opening of the vagina, so tumors can arise in any of these areas. The main risk factor is infection with certain types of human papillomavirus, HPV, especially HPV-16. Chronic skin conditions such as lichen sclerosis, a thin white patchy skin disease, can turn into cancer over many years. Smoking damages DNA and weakens the immune system, making HPV infection more likely to cause cancer. Some families carry genetic changes that raise risk, and older age, usually after 60, plus a precancerous lesion called vulvar intraepithelial neoplasia, VIN, also increase the chance of cancer. When HPV is present, the virus inserts its DNA into the cell and produces proteins E6, E7 that block normal cell cycle breaks, leading to uncontrolled growth. This is the HPV-dependent pathway. In women without HPV, long-standing inflammation from conditions like lichen sclerosis causes repeated damage and repair, eventually allowing abnormal cells to accumulate. HPV-independent pathway. The tumor surroundings, including immune cells and blood vessels, help the cancer spread to nearby lymph nodes and distant sites. Worldwide, vulvar cancer makes up about 5% of all gynecologic cancers. It mainly affects women, with an average diagnosis age of 65 to 70 years. Rates are higher in Western countries and among women of European descent, but incidence is rising slowly in some low and middle-income regions, likely because of better detection and changing HPV exposure patterns. Typical findings are a lump or ulcer that may be pink, red, or white, and can be larger than a pea. It often itches, pruritus, hurts, or feels like burning. Pain during sex, dyspareunia, is common, and some women notice swelling of the groin lymph nodes. Rarely, the tumor can cause skin changes elsewhere, perineoplastic signs, but this is not usual. Doctors first look at the vulva with a visual exam, sometimes using a magnifying lamp. If an abnormal area is seen, a small tissue sample is taken, either a punch, incisional, or excisional biopsy, and examined under a microscope to confirm cancer and its type. Imaging such as ultrasound, MRI, CT, or PET helps see how far the tumor has spread. Staging follows the FIGO or TNM system, which records tumor size, nodal involvement, and distant spread. Most vulvar cancers are squamous cell carcinoma. These are split into HPV-related, younger women linked to VIN, and HPV-independent, older women linked to lichen sclerosis. Less common types include basal cell carcinoma, melanoma, a pigment-producing tumor, and adenocarcinoma that arises from glandular tissue. Each type behaves differently and may need a specific treatment plan. Treatment depends on stage. Early tumors are often removed with a local excision or a partial vulvectomy, sometimes together with removal of nearby lymph nodes. Larger or deeper cancers may need a total vulvectomy and more extensive node dissection. Radiation external beams or brachytherapy can shrink tumors before surgery, or be used after surgery if margins are positive. Chemotherapy, often cisplatin-based, is added for advanced disease, and newer drugs that block PD-1/PDL1 are approved for recurrent or metastatic cases. Multidisciplinary guidelines recommend combining these approaches when needed, and after treatment, pelvic physiotherapy and counseling support recovery and quality of life. The best prevention is vaccination against HPV before sexual activity begins. The vaccine protects against the high-risk HPV types that cause most vulvar cancers. Quitting smoking reduces DNA damage and improves immune response. Regular checkups that look for VIN, especially in women with lichen sclerosis, allow early removal of precancerous lesions. Managing chronic skin conditions with potent topical steroids or other therapies also lowers cancer risk. Overall 5-year survival is about 70% for early-stage disease, but drops to below 30% when the cancer has spread to lymph nodes or distant organs. Important predictors of a good outcome are clear surgical margins and no nodal involvement. Recurrence most often appears locally within the first 2 years, so follow-up visits every 3 to 6 months for the first 2 years, then yearly are recommended. Imaging may be repeated if symptoms return. Research is focusing on finding molecular markers like P16, TP53 mutations that predict response to therapy. Genomic profiling helps match patients to targeted drugs, such as EGFR inhibitors for tumors with specific alterations. Ongoing trials test new immunotherapies, for example pembrolizumab, and combinations with radiation. Surgeons are using minimally invasive techniques like sentinel node mapping to avoid full lymph node removal and reduce lymphedema. Personalized vaccine strategies and broader HPV vaccine coverage are also being explored to lower future cases.